Hello, everyone. Welcome to the Cardiac Wire Show. My name is Jake Fishman. I'm the host of the show and the editor of the Cardiac Wire, and we have a great episode for you all today. We have Nishith Khandwala from Bunkerhill Health joining us. Nish is the CEO and co-founder of Bunkerhill, and they're doing some really neat things around AI sourcing, AI validation, and AI distribution, some stuff that we're truly not seeing anywhere else. Nish, welcome to the show.
Thanks for having me, Jake.
It's great to have you here. Just to start us off, maybe you can give a quick introduction to yourself and your background, and then, big picture what Bunkerhill Health does.
Yeah, again, thanks for having me. I am the CEO of Bunkerhill, and previously to Bunkerhill, I was a graduate student at Stanford working in the AI for medicine and imaging group there. And as a computer scientist, I used to build different algorithms for use cases in healthcare as a part of that center. We would build algorithms, we would write papers. It was a lot of fun. And, a few papers in, I got a little frustrated that those algorithms were just sitting on my laptop and not being used in clinical practice, and tried to really understand what would it really take to bring those models, those algorithms from my laptop to the clinic. Realized those are really difficult, but a really fun problem. And so we spun out of Stanford to launch this company called Bunkerhill, whose goal is to bring ideas to the clinic as quickly, as safely as possible in the realm of AI.
That's amazing. And it really is solving a problem. I mean, we've been producing the imaging wire for 6 years, and maybe thousands of algorithms we've covered that, maybe contributed to overall science in that dotted line way, but, did not maybe see the, impact healthcare the way they might have without something like this. So it's really neat.
Yeah. And, those models have a lot of clinical value. They even have a lot of financial value for different healthcare stakeholders. But despite of that, these models, these algorithms are just not making it to the clinic. And there's just a ton of friction to bring those to market. And it's a big problem, but it's one of those problems where if you solve it, you unlock a tremendous amount of value.
Right. And so one other thing that is, truly unique in this, big world of healthcare AI that, I'm seeing with Bunkerhill Health that I'm not seeing elsewhere is your consortium approach. And I was curious if you can just share more about how that works and then some success stories within it.
Yeah, absolutely. So if you think about bringing an idea to the clinic, let's say you're a researcher at Stanford, you have trained and tested a model on Stanford's data. Now, in order for that model to make it to widespread adoption, there are a couple of steps. On a high level, you need to make sure, the first step is you need to make sure that your algorithm performs consistently well across different health systems. In order to do that, you need a lot of data from a lot of different hospitals. The second step is to get regulatory clearances. And then the third step is to actually build the distribution to deploy and integrate these algorithms into the workflow of physicians. At each step, it's really vague. It's not clear how do you get started, especially as a researcher who's focused on academics and on research, as opposed to go to market. And on top of that, even if you didn't know what the steps were for each of those phases, it's just filled with a ton of friction. Like, to give you an idea, when I was at Stanford, to get my algorithm validated from a couple of different institutions, I spent about 1.5 years negotiating those data sharing agreements between Stanford and those other institutions so that I could get access to their data and then validate my algorithm on their data. And the worst part about all of that was that it's not reusable. So if I wanted to do that for my second algorithm, or if someone else from the other institutions wanted to do it for theirs, they would have to start from scratch again. Our company's idea around a consortium is an attempt to solving that problem. So what this consortium is, think of it as a legal bubble. And this consortium has 25 academic medical centers and growing right now. You have Stanford, UCSF, Harvard, and a couple of other institutions like MedStar as a part of this consortium. And what this consortium, being a legal bubble, allows researchers to do is collaborate across institutional boundaries to build algorithms together, to validate each of those algorithms, to train it on data from other hospitals. And and really just make it a research playground for them to work with each other without having to go through the red tape or the bureaucracy that currently becomes a really prohibiting factor for multi-institutional collaboration. So this consortium that we have set up allows researchers to build and validate algorithms, and when they're ready, when they're done with their research, they have the option for Bunkerhill to go and commercialize those algorithms that are then validated, in which case we would file for regulatory clearance and distribute the algorithm to other health systems. And whatever revenue we make of that commercialization, we share the majority actually back with the institutions in the consortium that contributed to the algorithm itself.
Are there any specific stories or cases that help tell that story in a specific way?
Yeah. So there was a Stanford cardiologist, Dr. David Marin. He's the head of preventive cardiology there. And he used to see patients in his clinic after they had a heart attack or a stroke. And he would look back at their records from 4 or 5 years ago, and he would see that the patient got a CT scan of the chest, like a non-gated one, for some other reason, like, they came in for a car crash or they came in with a pneumonia and they got a CT scan of the chest. And he would find coronary artery calcification, like calcium plaques in the arteries on those chest CTs, and nothing was done to those patients. Those patients were not followed up with. The patients were not brought to the preventive clinic, and the patient had to go through a heart attack before they actually made it to his clinic. And so he saw this as an untapped opportunity, and he built an algorithm along with a radiologist at Stanford to do exactly that, which is, can you quantify coronary artery calcium on chest CTs acquired for non-cardiovascular reasons? So it's an opportunistic screening algorithm. They created it at Stanford, and they used our consortium to validate the algorithm on 7 other institutions' data. And we took that data, used that for FDA clearance, and we obtained it. And now we have actually distributed and deployed the algorithm at over 300 sites. And super excited to say that we are on track to running the algorithm on over 200,000 patients this year.
Wow. What can, say a system runs the CT scan on 50,000 patients or something like that. How many previously unidentified high CAC score patients do you think?
Yeah. So if you look at the funnel, so let's say you have like 50,000, let's just say 5,000 for that's typically the size of how many CT scans a mid-sized hospital would do. So you have 5,000 scans that you acquire in a year. Out of those, you will see that roughly half, like 50%, have a very high coronary calcium score, where high is defined as greater than 100. But not all of them are unaware of their cardiovascular risks. Some of them would already be seeing a cardiologist. Some of them would have, in fact, even had a bypass surgery or a stent. And so out of those 50%, roughly, if you look at all the numbers, roughly 12% of the patients overall have a high coronary calcium score and no previous diagnosis of any cardiovascular disease, no previous statins. So these are what we call cardiology naive patients who are at high risk and could benefit from preventive care.
Right. So it's like, over 500 patients per hospital per year.
Exactly. And we expect, not every patient when followed up with is going to show up. So, but from a randomized control trial that was done, we saw that roughly half of those patients who are followed up with actually show up for their follow-up appointments and treatments.
Right. And I remember I think it was a Stanford trial that showed that when these patients get identified, they have a far higher rate of getting on statins and then
exactly
care.
Yeah. And then not just statins, like prescriptions, also adherence, because they see, the cardiologists there have a thesis that when you show the patient an image of your sort of arteries and where you can see where the calcium is, and you can very clearly make out that white stuff where there should not be there, it leads to patients actually getting started on statins, be more willing to do that and actually adhere to that medication and to that prescription because of that increased awareness of what it means for their health, as opposed to some number like your cholesterol levels or anything else.
Okay. So devil's advocate here, 3 weeks ago, the FDA came out with their latest count of all the AI products that are out there, and there's like 800 and something.
Yeah.
I actually believe there's actually less than 800, but that's a side story.
Yeah.
Why not just launch a marketplace?
Yeah. On the surface, it seems like a marketplace where you take companies that are building algorithms and got on the FDA clearance and just distribute them should work. But if you dig a little bit deeper from first principles, it seems like that model seems fundamentally structurally flawed to me. What I mean by that is, these the companies that are creating those algorithms that are getting those FDA cleared, they are all venture backed and they're expecting venture type returns, which means that you're going to be the dominant player in your space. And it's really hard to do that when you give up your distribution to someone else. Let me put it another way, actually. If you're a marketplace of where the algorithms are coming from companies that have built and validated and got an FDA clearance for those algorithms, you are making an assumption that there will be hundreds of those companies that thrive and succeed. Now, intuitively, we all know that it's not going to play out where there are going to be hundreds of companies that thrive in the space. There will be a lot of consolidation, a lot of companies that close shop. And we're already seeing that, if you look at RSNA 2017 to 2023, like you do see later a lot fewer new players into the market. And that's a sign that you are not going to see a world where there are going to be hundreds of these companies that thrive. And so if you're a marketplace, your supply side is probably going to dwindle over time, and it's not something that is sustainable for the future. Now, if you think about it, again, from bottoms up as opposed to like a high-level view, again, in these companies that are building these models are venture-backed, they're expecting venture-type returns. And there are two ways to have venture-type returns, which is you dominate the market. It's either through defensibility coming from IP protection, like patents, but you're seeing that that's not really the play in AI for medical imaging, at least. And then the other way to have dominance in the market is by having distribution, which is it's really hard for your customers to switch off of you and go to your competitor. Now, if you as a company who doesn't have IP defensibility puts your algorithms on another companies like a marketplace for distribution, you're giving up that distribution. By construction, a hospital using a marketplace could switch between different companies fairly easily. That is, in fact, the selling point for it. And so in that case, the companies that are building those algorithms might not be able to deliver those venture type returns because they would not be in a place where they would dominate the market. And so for all of those reasons, we realized that a marketplace sort of idea is not necessarily very structurally sound. On the other hand, our approach of going to researchers, to academic researchers, to individual developers, to bootstrapped companies and getting their algorithms, the incentives are very aligned. Researchers don't want to go through the FDA clearance process themselves. They don't want to be on call answering or picking up a phone at 4 a.m. Taking care of a customer success issue. They want this to be something where someone else takes care of it. And every dollar that they make would be a dollar that they were not expecting to see otherwise. And so for those reasons, like we thrive when our supply side of researchers thrives and vice versa. We are not, our incentives are not orthogonal, they are very aligned. And so that's why we went with this approach as opposed to something that else you see in the market. And that's mostly from like logical reasons. The personal reason was I was a researcher myself, and as a researcher, I did not really see an option available to me to get my algorithms. The marketplaces that we are thinking of, they do not cater to algorithms being built by academic researchers.
Okay, so that puts you in a situation where you have to pick among those thousands of academic and research AI projects, and figure out who to partner with and what algorithms to invest in and bring to market. How do you select which algorithms and partners to work with?
Yeah, so our consortium idea or a model is meant to scale, and it's meant to have its own sort of internal checks and balances. We do not want to be in a position where Bunkerhill is making the decisions on which algorithms to bring to market and which not. We do not want to be in a position where Bunkerhill is the one making the decision what science is done and what science is not done. I think that that's a slippery slope, and it's also not scalable. So the way we've designed this consortium is you are not going to see a lot of algorithms that make it all the way through the training and the validation process with successful results unless the algorithm was actually very valuable and something that we were really excited by to begin with. And so think about it this way. In this consortium, Bunkerhill is not the one doing the research. It's the research collective that is doing that research. And so someone who has built an algorithm, in order for them to do a validation study across multiple institutions, requires effort. Even though, we take away a lot of the paperwork and a lot of the bureaucracy, you still have to do the scientific work. You still have to do the research work to validate your algorithm on data from other hospitals through us. A researcher who has built an algorithm is not going to do that for an algorithm that they're not excited by. Similarly, the institutions that are helping with the validation or with the training, they are not going to contribute or participate in a project where they are not excited by the utility of the algorithm. And the incentive for those institutions, they now get to use the algorithm for free in perpetuity. That's how we have proctored our agreements. And so those institutions, they cast a vote. Yes, I'm interested in this algorithm. I see a lot of utility. No, I don't. So I don't want to participate. And so that itself is a checks and balance thing. And then finally, when the validation study does happen, the validation is not just, hey, does my algorithm generalize? It's also like, what is the utility of the algorithm? And if those validation studies come out positive, at the end, we have an algorithm that we would be foolish not to take to market. And so we don't need to make active decisions about, or we have structured it in a way where we don't need to make active decisions about which algorithms to support and which ones not to.
Right. Yeah. If those 28 institutions decide that a algorithm does or does not have clinical utility, you can probably assume that 2,800 other institutions would agree.
Exactly. Built by clinicians for clinicians,
Right. Okay. So we're at, I don't know, say if healthcare AI is a baseball game, we're probably like in the first inning, right? But there's your vision for today, which actually is really interesting and impressive. When you look at Bunker Health into the future, what's your vision for Bunker Health and how you fit within the healthcare AI paradigm going forward?
Yeah. Our goal as a company, our vision is to bring ideas to the clinic as quickly as possible for AI. And so you have to think about every phase of that idea to clinic deployment journey, all the way from building the algorithm itself, even coming up with the use case, to validating the algorithm, to getting it FDA cleared or cleared by the regulatory bodies, and then distributed in a widespread setting. And so our vision for the company is to make it as easy as possible for anyone with an idea to go through that process. And so for each phase, we are building products, we are building ecosystems to allow for that. So in order for someone to take their idea into a proof of concept model, we're building a foundation model using millions and millions of scans from this consortium so that researchers can start with that foundation model as a building block, as opposed to starting from scratch, and be able to build models for use cases rapidly, say in an afternoon, as opposed to spending a couple of months annotating a vast number of studies and building a model from scratch. On the validation side, we have a consortium that we have built where you can rapidly validate algorithms, get access to data, run studies, not just retrospective, but prospective as well, to prove out the utility of the algorithm. And we hope that our consortium allows for that rapid ability. And then on the FDA clearance side, we'll be working very closely with the FDA to streamline submissions as the number of submissions grows into double digits and triple digits down the road. And then on the distribution side, we've done some great work in signing up really great customers and really large health networks where we'll be able to offer hundreds, if not thousands of sites as deployment network for the algorithms that are coming from the consortium. So we really want to make it as easy as possible for those ideas to get to the clinic. So that's the vision behind the company. That's how we make decisions about what we pursue and what we don't as initiatives.
Got it. And so much of what we've talked about for AI, I don't know, for the last 5 years or since RSNA 2017, has been around imaging AI. But healthcare AI is, of course, not limited to that.
Yes.
How do you see AI expanding to new modalities and use cases, including stuff beyond what we're talking about today?
Regardless of the specialty, whether that's radiology, pathology, genomics, cardiac modalities like EKGs and echoes, or even EHR, models. For all of them, regardless of the specialty, you need a way to take your idea and rapidly build a model around it. You still need a way to validate your algorithm on data from multiple hospitals. You still need a way to get your algorithm regulatory cleared. And you still need a way to distribute your algorithm to as many health systems and as many healthcare stakeholders as possible. And so as we think about our approach, we at no point want to limit ourselves to just radiology or just to a specific specialty. We have from day one, we want to create something that is sustainable and replicable across different specialties. We're just starting with radiology today because it's close to heart. A lot of our initial work wasn't there. And also it's the White Hot Center for Research today. As you probably have seen from the FDA announcements, the vast majority of those 800 plus algorithms that have been FDA cleared are in radiology. So we thought that it would be the best place to start with. But as the other fields evolve, as they catch up to imaging in terms of AI, our consortium, our distribution network, Bunkerhill's interest would be ready to take those ideas to the clinic as quickly as possible as well.
For sure. And those other institutions are certainly handling plenty of, ECGs and have plenty of EHR data and all of that stuff.
Yeah. And LLMs have been sort of an interesting, or they have been an interesting enabler. In the past, you could say, EHR algorithms would be hard to generalize because EHR data is so unstructured, so variable across institutions. But LLMs are a great way of taking all of that unstructured data and making it structured and seeing if you could actually have interesting EHR algorithms on top. So I see this, as we chat, I get super excited about what the potential of this field and industry could be as we think about how AI helps medicine or healthcare more broadly.
Right. I'm excited too.
Yeah.
Nish, thanks so much for sharing this. And, once again, congratulations on coming up with a truly innovative way to, help bring life to like one of the biggest innovative areas of medicine that was kind of dying on the vine after it was being developed. It's really cool to see.
I really appreciate you saying that, Jack. Thanks for having me.
It was great to have you. And for folks who are watching, thanks for joining us. If you're an AI developer, on the academic side or on the bootstrap side, reach out to Nish. They have, for the folks on the cardiology side who are watching, they have some amazing cardiovascular algorithms right now that are worth checking out too. And I'll catch you all next time.